The first two talks combine two new areas in the treatment of endovascular therapy. The first one is the use of these devices in the ascending aorta, which we all know is a complex anatomy where there are differences in terms of the anatomy where we deal with the subclavian artery, the proximity of the other vessels to the head, and then the dynamics of increased flow and pressure in the ascending aorta, so that some of the things that we see in other cases are more difficult here. The other is to decide not only where to place these devices, but what the lengths are. And in particular, we usually work with the center line, but for the ascending, you'll see the outside diameter is particularly important. When you look at the dynamics of flow in the ascending aorta, there are places where the stress points are particularly high related to the dissections, and we'll discuss that in a minute. The first part of this was to be able to look at some cases just to decide how pulsatile the aorta is at various locations, and we did that in two places here in the ascending aorta and then at the arch. And these were made for comparison measurements of the intravascular ultrasound in systole and diastole, so that we're able to look at a dynamic component of how the aorta expands. And when you do that, and it's not particularly surprising across these various pathologies, that where the compliance levels are lower, they are in the aneurysms and the penetrating ulcers, and higher in the dissections and in patients that have traumatic lesions. So when you look at this across patient groups then, and we look at it related to age, the compliance decreases at about 4% per year, or per 10 years. These are on the bottom scale, the ages. And over time, then the compliance decreases. So looking at these, then it has an implication on the sizing is where we put these, and I'll show you in a moment how it works. Now, there have been several reports in the literature looking at ascending grafts for various indications, including dissections, as I'll show you in a moment. This is another paper we published. And then trying to estimate what percentage of patients might actually be candidates for ascending grafts compared to surgery. There's speculation that this may be as high as 30% or more. So it's not an insignificant group of patients. In our institution, we have what's called a physician-sponsored IDE, where we work with the FDA and have an approval based on a lot of early work to try and see these tubular anatomies and how they fit the anatomy. There's two variations of devices. One's, and these are shorter, they range from 6 to 10 centimeters in length, with some having these proximal stents on the aortic side and the other on the top, so that we could make variations to fit the anatomy. The inclusion criteria for this, for the FDA, was to treat not aneurysms but just tubular lesions, so that we could actually make those fit specifically to the anatomy. This is obviously done in a room, and you'll see from Dr. Lumsden in a minute a lot of the components, but it takes laying these cases out very much like you're doing a transaortic valve replacement, so that we're going to emphasize where we place this in terms of the room. This is an example of our facility where we have a Zigo room and the ability to combine all these technologies, and it's really a group that has high specialty. We use the OR CV staff in order to coordinate it, CV anesthesia, and to have specialties that can work not only with the TEE, but transesophageal and TCD. And really it's a combination of all of these imaging characteristics then, not only to select the patients, but during the procedure. And as I mentioned, these look like transaortic valve cases, if you've been involved in those, where we focus on laying this out to see where the coronary arteries are and how we're going to be able to deploy these devices in the ascending aorta. A lot of these decisions are made based on transesophageal echo with the last minute trying to decide where these are going to be. And these are just a few cases. An example here of a penetrating ulcer, where, as I mentioned, we lay that, sorry, this skips ahead. We lay that out as though it's being positioned for a valve device. And then as we deploy, you can see in this case, here the endograft is in position now, and we assure that covered the lesion. We do a lot of ancillary procedures at times in order to get further up the arch. This is a patient that I just showed you, and we weren't sure we had enough landing zones, so we actually had a carotid ahead of time in case we came up and encroached on that innominate artery. This is another example of a case with a penetrating ulcer. Here you can see the aortic valve where we want to deploy this above the coronaries. And it appears then on this TE we have enough landing zone to put that device in, this being the transitional view of that. And then here after deployment of the endograft. And this is patients now that we've seen, this was out to a year's follow-up. And what we're looking for in the initial cases are, can we actually deploy these where we want them? Are they stable and heal in place? And this is that same patient. We have some now out to 4 years to be able to look at how that anatomy heals and whether these are stable. Another example of a patient with a post-surgical lesion, covering that with the endograft, and then again the serially imaging out to, in this case again, 4 years to be able to see how that aorta remodels and what the device stability is. Another example here, post-surgical pseudoaneurysm, covering of that lesion, and this patient's been out now to about 3 years. You can also see he had a descending lesion and infrarenal. Many of these patients have, as we know, not only just ascending lesions, but places in the other part of the aorta. And this is that same patient then again on serial images and follow-up. Another case, very difficult patient here with a very large pseudoaneurysm. He has a prosthetic valve, which is a consideration to be able to put the device in and pace these patients and then cross the valve to deploy it. And you can see how here above the valve he has a graft which with this pulsatile flow very much collapses, so he's in pretty much extremis by the time we saw him and were able to treat this. We were able to position a device based on these imaging, again just above the valve and up, and this is him over time where he thrombosed that lesion and continues to regress that big pseudoaneurysm. One final area I'll address is the ascending dissections. This is a problematic area for all of us from a surgical perspective. A lot of these patients, as you know, have many we're trying to see where this entry tear is in the aorta, and either they're replaced initially with a tube graft or more extensive surgical repairs. This is an example of a patient who actually happened to be in the hospital, so it was the 3D representation. This red part is the true lumen, the blue part is the false lumen. You can see how with systole that flap nearly collapses and why he's in hemodynamic collapse. These are examples of the TEs at the time. Here's the valve, and what we're looking for is an adequate length of landing zone in order to be able to cover that with the endograft. You can see here, again on the TE, the valve mechanism. Here's the flap, so it looks like we have enough to be able to cover that. This is in the other view. We want to make sure that the coronaries are intact and there's no leakage around. This is the angiogram. You can see the dissection. We want to make sure that we can connect through to the cerebral vessels, and on a intravascular ultrasound, we look along the length of that to be able to make sure that we can see that it communicates with the head. As I mentioned, these cases then get laid out very much like it's a TAVI case. We want to be able to land here just above the coronaries. This is confirming that we can see in the head vessels that it translates up to the head, and we're not going to put a device in there and then not have circulation to the cerebral area. After the deployment of the device, this is at the coronaries, and then directly above that you can see expansion. Here's the corresponding angiogram with flow to the head. As I mentioned, we confirm that with the ultrasound to make sure we haven't disrupted the circulation around the top of the arch. And then the TEEs afterwards, these are the stills. Here's the valve and the device. And then here on the TEE image, actively you can see the struts of the device and up along the aorta, how it's expanded. And this patient, and all of them, we've done 3 of these very quickly. Their hemodynamics straighten out. They were all set to be put on a pump, and we break it down, and then it really ends the case very quickly with everybody being pleased about the results. This patient, this is a 1-year follow-up on that same patient. So here's the endograft. He's nearly healed the ascending aorta. These folks still have the descending component, but those can be treated with other methods that are currently under development. So another patient with an MR came into the emergency room and had this image from an outside institution. You can see the disruption, and this is that same patient who had not only the ascending repair, but then after that a descending repair so that it can keep going serially around the aorta depending on what the anatomy is. It's another patient who was treated after a TAVI valve case. There was disruption of the ascending aorta, and we were able to put a piece in there, and this is the follow-up image. So these are not all without complications, and I don't want to make it sound like things don't happen adversely, but we've been able to look at this, and these devices really don't migrate. If they're sized appropriately, they stay in place. It's very easy if the valve motion is in the way to entrap a valve, so you have to be set up to be able, if that happens, to repace the patient and displace the valve. We've had that happen once. And so really having what we call these bailout setups to be able to move and treat other issues is important. We adhere to a very strict, as I mentioned, TAVI valve protocol where we pace the patient's aim and put the devices where we want them. There are ways to obviously minimize the valve variation with pacing or even to give the patients adenosine. The hybrid room is very important, and we've been able to show the durability of these over time with them staying in place, and that these lesions remodel, so that replacement in the ascending aorta is very promising. Another way to try to address these is with transapical access. We're all familiar with what that looks like. And these, particularly in patients that maybe have a horizontal anatomy or a difficult lesion to treat. Where this is going to go is potentially combining this in an additional set of patients who have valve insufficiency, but the coronaries aren't involved, to be able to add to that a valve. There are some variations, and you've seen other devices that'll help us be able to continue to treat around the aorta for these other lesions, and you've seen these. One of the other things that's important in this area is to look at embolization related to this. We've all seen this with the TAVI valve cases. This is from data, some from the ACC, where they're actually now calling these lesions microbleeds that have long-term implications. And I know Dr. Lumsden will talk to you later about some ways to characterize these, but treating these embolizations and cutting down the events in the procedure is going to be particularly important. So the impact has been very, not only in the thoracoabdominal aorta, but in the ascending now, being able to treat selected lesions, and hopefully these are going to be able to, like it has in the descending aorta, replace